Our next speaker, Dr. Marc Hickeson, he did complete his medical school at the University of Ottawa in 1996, followed by a residency training program in nuclear medicine at McGill University in 2000. And then he did a nuclear oncology fellowship at the University of Pennsylvania in 2002. He's currently the assistant professor at McGill University Health Science Center since 2005 and the residency program director of nuclear medicine since 2009. It has the pleasure to work with him as a resident. He was my supervisor and my program director. And right now I'm introducing him for the next talk about gallium and infection.
Oh, thank you for this nice introduction. And well, it's my pleasure to have the opportunity to present in front of a lot of familiar faces. Now I'm just going to get used to this this pointer. So my topic will be about gallium imaging for infection. It's a very broad topic, so we only got 30 minutes. So I'm going to try to cover the main point. Is it about osteomyelitis or soft tissue infection? But first, the thing I want to say, I have no commercial disclosures. What I want to talk about is the overview of the pathophysiology and inflammation of infection and inflammation, and talk a bit about gallium because that's what we're using for imaging. And then I'll show some cases about gallium imaging that we thought that were potentially helpful for infection. And I'll finish by summarizing the advantages and disadvantages of gallium imaging. So let's start with the introduction now. What is inflammation? It's just how your body reacts to any injury of any time. And infection is inflammation that's due to an infectious pathogen like a bacteria or a virus. And we can also classify infection based on the duration of the inflammation. Acute being less than 8 to 10 days and chronic longer than 8 to 10 days. So I just asked a question. I don't know if, you know, just in case we had this transponder, and which of these following is not a cardinal sign of infection according to Celsius? Is it pain, pallor, swelling, heat, or redness? Okay, if you had the time to look at it, you don't have to raise your hand or anything. As you can see here, the proper answer is pallor, and we see on the right of the slide, we see some of the signs of inflammation in the ingrown toenail. So this slide just illustrates what happens with inflammation. So you get increased blood flow, you get vascular permeability, and you get exudate formation and leukocyte accumulation at the site of the tissue injury. And it was well known for close to 2,000 years that the 4 cardinal signs of infection were heat, pain, redness, and swelling, or Kahler, Daler, Ruber, and tumor. Now, inflammation, you can have 3 different outcomes. The best case scenario would be on the left. You could get total resolution and regeneration, and you normal tissue at the site of injury. The next scenario, you get repair, so you get resolution of the infection with scar tissue. And lastly, in the worst case scenario, you get chronic inflammation. And chronic inflammation is considered to be the bad inflammation, and you get reduction of PMN at the site of inflammation or infection, and macrophage, lymphocyte, plasma cells, and fibroblasts begin to predominate at the site of chronic inflammation instead of neutrophils. It's often a diagnostic challenge. And why is it pertinent? Because it is considered to be a culprit for many of the age-related diseases, including Alzheimer's disease, atherosclerosis, diabetes. So, so this picture here is basically a mini. So this is gallium. Gallium is a solid metal that if you put in your hand, it just melts. And I cannot think of any other metals that will melt in your hand um, because of the melting point of 29.8 degrees Celsius. It behaves like iron, the 3 plus valence. Gallium-68 has a 78-hour physical half-life with 4 principal energy windows at 93, 184, 296, and 388 keV. The radiopharmaceutical that we use is gallium-67 citrate. Gallium accumulates at the site of infection based on binding with transferrin. Transferrin is a transporter for iron, and at the normal pH, the iron transferrin or gallium transferrin complex is stable. In addition, with inflammation or infection, you get increased blood flow, thus increased delivery of gallium at the site of injury. You get increased vascular membrane permeability. And at site of infection, the local pH is low, which lead to the dissociation of gallium from lactoferrin, and gallium does accumulate because it binds to lactoferrin. In addition, if there is presence of bacteria which contain CIDR4, CIDR4 has a very high affinity to gallium, so that also increases the gallium accumulation. Image acquisition, we do 24 to 72 hour delayed images, planar images, and we do a Spect CT at the site of clinical concern for more accurate localization. If there is a uncertain finding, for example, activity in the bowel, we would ask the patient to come back for up to a week later to see if the activity moves from the current scan. And I have seen early images at 3 to 4 hours after gallium injection to determine if there is pathologic accumulation of gallium in the abdominal cavity. So availability of gallium, I just want to quickly mention that we're currently get our gallium from Lantheus, who will discontinue supplying gallium as of January 1st, 2023. And there's also, we can get also gallium from Curium. This is how much we're paying for gallium. It's $650 for 13.2 millicuries, $950 for 19.8 millicuries. Okay, so precaution. This picture on the right is a breastfeeding patient, and lactation and pregnancy are considered to be relative contraindication. As we can see, that gallium avidly accumulates in the breast with a physical, a biological half-life of 9 days in the breast milk. So If the requisition comes up and the patient is breastfeeding, we determine if the gallium image is urgent or not. If it's not urgent, we can ask the patient to stop breastfeeding 2 weeks before doing a gallium scan to minimize the radiation dose to the patient's breast. If the examination is indeed urgent, we would do the gallium scan and we would ask the patient to discontinue breastfeeding for 2 to 4 weeks after gallium injection to minimize the radiation dose to the nursing infant. Now, this is an important slide. This is the interpretation criteria for 3-phase bone scan and Gallium imaging. And the main question is the bone infected? Yes or no? We know the patient has infection. We want to know if there is osteomyelitis. So if the Gallium scintigraphy is negative, regardless of the bone scan result, it is negative. And the other criteria is that if the distribution of activity of the bone scan and the gallium is geographically congruent. With the bone scan being more intense than the gallium, this is considered to be negative for osteomyelitis. Now, the criteria for positivity for osteomyelitis is the distribution of activity on both study is spatially congruent, with the relative intensity of gallium being greater than that of the bone scan. Or if the activity of both study is spatially incongruent, with the gallium being more extensive than on the bone scan in at least one region. And unfortunately, a lot of patients who has a bone and gallium scan are being currently treated with antibiotics, and we're faced with patients who have partially treated osteomyelitis. And so we have a third category is the distribution of activity of both studies is spatially congruent and equal intensity. So, well, we do lots of feet in at the MUAC. So I'm going to show you a few cases of feet infection. So start with the first case. It's a 69-year-old woman with infected left first toe, and the patient has osteomyelitis. So we see on the left, the blood pool shows increased uptake, so this increased flow on the tip of the left first toe. On the middle slide with the red arrow, there is increased, mildly, trivial increased activity in the tip of the left first toe, sorry, and the gallium shows increased activity. So there's no evidence of osteomyelitis. This is considered to be a soft tissue infection. Now, the second case is a 36-year-old male with type 1 diabetes and left first toe infection. Now, does that patient has osteomyelitis? This is the question that we have to answer. So we have marked hyperemia this time, marked blood pool activity, markedly increased bone tracer activity in the proximal phalanx of the left first toe with intense gallium activity. So this is considered to be, we did also a Spect CT here, and we see particularly on the middle image on the left side on the CT, we see an ulcer in the medial surface of the left first toe. And we see gallium activity, very intense gallium activity in the proximal phalanx of the left first toe. So that was considered to be osteomyelitis. So just ask another question regarding Spect CT now. Is it 100% predicted for absence of osteomyelitis if you have a negative scan? Or is it 100% predictive of osteomyelitis if you have a positive scan? Or is gallium images more sensitive for Staph aureus than Streptococcus pyogenes? Or the sensitivity of gallium is markedly decreased in chronic infection? You don't have to show me the answer. I just want to give you a couple seconds. If you said the absence of abnormal gamma activity essentially rules out osteomyelitis, that is the proper answer. So there are some criteria that for positivity for osteomyelitis that was published with Spect CT. So positivity for osteomyelitis if you have gallium uptake in the bone with overlying ulcer. Negativity for osteomyelitis if there's no gallium uptake in the presence of an overlying ulcer. And that group reported that it was 100% sensitive and 57% specific for osteomyelitis. The main cause of false positive you have to be aware of is misregistration. So this is very problematic, particularly the feet. It is a patient can move, if the patient moves the foot by couple millimeters, you can have a misregistration and a incorrect interpretation. And also, you can have acute fracture resulting in increased activity. Okay, I'll show you this case here of a 64-year-old male with diabetic foot infection. Now, this patient has osteomyelitis. So we see intense gallium activity in the right fifth metatarsal, and we see with the green arrow there's an overlying ulcer. So this is considered to be positive for osteomyelitis. This next case is a patient has an extensive heel ulcer, and bone and gallium was ordered to determine if the patient has osteomyelitis. We see the flow shows markedly increased blood flow in the right heel, and we see increased bone trace activity in the plantar surface of the right calcaneus, and the gamma activity has a different distribution. We order Spect CT and on both the bone scan and the gamma scan, and we see clearly on the bone scan on top and the gamma scan on the bottom that whatever shows increased bone trace activity, the plantar surface of the left calcaneus shows increased activity, but the gamma activity is confined to the soft tissues. So our impression was a soft tissue infection in the right heel with no evidence of osteomyelitis. And we have increased bone trace activity in the right calcaneus that was thought to be due to localized hyperemia, but could also be due to encephalopathy or bone contusion. So another case here, a 63-year-old male with poorly controlled diabetes and left ankle pain. We see increased flow in the left ankle region. The middle slide, the bottom, shows increased bone tracer activity, and the gallium images show much less intense activity. So we did also the Spect CT on bone and gallium, and we see on the CT component of it there is marked dysmorphism in the tarsal bone, and so this was considered to be not infected. The bone tracer activity was much greater than the gamma activity, and the findings was due to Charcot joints. The joint was actually aspirated and the tarsal bone were biopsied, and no infection was detected. Okay, now we're leaving the feet. Now we're going to the head and neck. The skull is actually a very challenging structure to assess for osteomyelitis, particularly in cases with multiple surgeries. And this is a case of a 67-year-old woman with multiple craniotomy, has an ulcer and draining sinus in the frontal bone, and the bone scan shows increased activity involving the frontal bone on the left side and adjacent frontal sinus. And the Gallium scan shows more intense focal activity in the left frontal bone. So this was considered to be positive for active infection. Okay, now imaging of the spine. So we can have a role for evaluating for infection in the spine. So this is an 84-year-old male with severe low back pain. Well, that patient was also on antibiotic at the time of the scan. So that's why we don't see as high Gallium activity than on the bone scan. But we did a Spect CT. The Spect CT shows increased activity, well, Gallium activity that is localized deep in the intervertebral space of L3, L4, and that was considered to be partially treated infection despite the modest Gallium activity. The next case is a 63-year-old male with sacral ulcer. Bone Gallium scan was ordered to evaluate for osteomyelitis. We see in the top row, there's evidence of a deep sacral ulcer. The Gallium images in the middle shows intense Gallium accumulation at the sacral ulcer, but the uptake did not really involve the sacrum. We did also the bone scan. There was no uptake of, as you can see, and we see on the sagittal on the left, there is no uptake in the sacrum on the bone scan. So this was considered to be negative for osteomyelitis. So as opposed to the next case is a patient with an infective ulcer overlying the left ischium. So on the left side, or on the top two slides are the bone scan, and we see the focus of intense activity involving the left ischium. The Gallium images shows more extensive activity at the same site and overlying soft tissues. The Spect CT shows evidence of a sacral ulcer. I don't know if you see it well. And the Gallium scan shows Gallium accumulation in the ischium. So the bone is involved, and that is positive for active osteomyelitis. Okay, just another question in case you want to have a question. The technologist shows bone and Gallium images of this 53-year-old female. The requisition says rule out osteomyelitis of the right hip. What additional pictures would you ask? Will you ask for a repeat Gallium image in 24 hours, or Spect CT of the pelvis, right lateral view of the pelvis, repeat Gallium images with a different energy collimator, or you want to repeat the Gallium images with the correct Gallium energy window? Well, we did have a Spect CT, so the proper answer was we will order a Spect CT. And then this is a 53-year-old female with infected ulcer posterior to the right hip. We clearly see on the top right corner there is a deep ulcer. The bone and Gallium scan shows increased activity, and we can clearly see on the Spect CT that the right proximal femur shows intense gallium accumulation. Well, the right intertrochanteric region was actively infected with an overlying soft tissue ulcer, so that indicates positivity for infection. Okay, infection imaging in immunocompromised patient. I talk mostly about febrile neutropenia because we don't see too many patients with acquired immunodeficiency syndrome in our hospital. So febrile neutropenia, the definition is a fever and neutropenia. So fever is a temperature greater than 38.3 or equal to 38.3 degrees Celsius, or sustained oral temperature of 38 degrees Celsius or greater for more than 1 hour. Neutropenia is a neutrophil count of less than 500 cells per microliters, or neutrophil counts of less than 1,000 cells per microliters, with a predicted decrease to below 500 cells per microliters within the next 48 hours. So febrile neutropenia is considered to be problematic, particularly in patients who have malignancies on chemotherapy, and infection is considered to be a high cause of mortality and morbidity. CT, ultrasound, MRI are all valuable, but they're not very sensitive for early functional abnormalities. And that's where gallium imaging may have a role. In fact, well, FDG PET also is useful. But however, due to the high physiologic activity of FDG in the brain, the kidneys, and urinary bladder, these sites are better evaluated with gallium imaging. So I have the 29-year-old female with non-Hodgkin lymphoma, presenting with fever, neutropenia, and low back pain. We ordered a bone and gamma scan to assess for possible intra-abdominal abscess. I'm just going to show the gamma images only. There was no Spect CT at that center, but we see that there was increased activity in the upper pole of the left kidney. So the interpretation was infected left kidney. So this is the anterior images that was done on April 16. This is the non-contrast CT. They did not show any abnormality. A repeat CT that was done on May 13, this time with IV contrast, showed multiple abscess in the kidney, and the largest was in the left upper pole. Well, this was actually biopsied, and it was active fungal infection. So the gallium images were the first modality to detect active infection in that case. Now, fever of unknown origin. This is a not an uncommon presentation in our department. It's defined as a temperature of 38.3 degrees Celsius or higher for a minimum duration of 3 weeks without any established diagnosis, or with 1 week of investigation in the hospital. And that was the definition that was used 61 years ago. Well, this definition was changed to a minimum duration of 3 days of in-hospital investigation and 3 outpatient visits. So if you have a fever without any established diagnosis with 3 outpatient visit or 3 days of in-hospital investigation, you have a fever of unknown origin. And again, just to ask a question, what two broad categories of disease account for 2/3 of cases of fever of unknown origin? Is it cancer and infection, cancer and autoimmune disease, infection and autoimmune disease, vasculitis and cancer, or infection and drug-induced fever? Well, the proper answer is infection and autoimmune disease. So the differential diagnosis in adult, both infection and autoimmune disease account for about 33% of the causes, with cancer accounting for 18% and miscellaneous or others accounting for 16% of adults with fever of unknown origin. Despite extensive workout, the etiology of fever of unknown origin remains undiagnosed in 51% of the cases. I'll show a case of a 31-year-old male who has bacteremia and fever, and that patient had a Gallium scan. The patient had abnormal uptake in the left thorax. We ordered a Spect CT, and the Gallium activity localizes in the pulmonary valve. So the following day, the patient had a transesophageal echocardiogram that confirmed the presence of highly mobile vegetation attached to the prosthetic pulmonary valve leaflet. So differential diagnosis in children, very similar to adult, except that infection accounts for 41% of the cases with infection is the most common etiology, followed by autoimmune disease, then cancer, then others. Role of gallium imaging for patient with end-stage renal disease. Well, patient who has a renal transplant, they are immunosuppressed because of the anti-rejection medications. And if they have a renal transplant, the transplant has short ureters, so they're susceptible to have pyelonephritis. And now to finish, I'm going to talk about the advantages and disadvantages of gallium. So this, the last two slides will be the summary. So the advantage of gallium is that you have superior to other radiotracers for the evaluation of spinal infection. The uptake normalizes earlier than other radiotracers such as technetium. Although it's expensive, it's still not as expensive as indium-111 white blood cells. It has good sensitivity for acute and chronic infection, as well as non-infectious inflammation. And finally, there's a long track record with gallium. Disadvantage is you have a high radiation dose, poor imaging quality. We need to wait for at least 1 day for imaging after gallium injection. There's a limited specificity due to poor resolution. And if we're evaluating for intra-abdominal infection, you could have the physiologic intestinal activity that could hinder the evaluation for infection. And we are experiencing increasing limited access to gallium. Like Lantheus is stopping to supply gallium as of January 1st. Now, compared to other radiopharmaceutical, I don't want to steal the show from the previous presenter who did a very good presentation and other future presenter today. But I just want to say very quickly that gallium, it can be used with a gamma camera. If you don't have a PET scan in your department, gallium is still a reliable agent to evaluate for infection and osteomyelitis. White blood cell imaging is also very good, as we saw in the previous slide, and we'll see in the next slide, our next presentation will be FDG PET. I guess that's it. Thank you very much for your attention.